just wanted to revise with you the basic structures here. This is the base of the skull. This is where the brain sits. This is the frontal bone in blue, and here in the middle is the ethmoid bone, that is the crista galli. It's going to provide attachment to the one of the folds of the meninges, the falx cerebri, and this is the cribriform plate of ethmoid where the olfactory nerve fibers go through. And this in orange or in yellow is the sphenoid bone, that is the lesser wing. This is the greater wing. And here is the sella turcica where the pituitary gland sits. This in purple or in pink is the temporal bone. This is the squamous part, and this is the petrous part. I'm going over these because they will provide attachments to the folds of the meninges. This is the occipital fossa, and this is the foramen magnum. This is the jugular foramen, where all the venous sinuses of the brain will drain eventually into a one single vein on each side. The jugular vein is going to pass through this jugular foramen. But for now, let's start with the meninges. As you know, brain and spinal cord, they are covered by meninges, 3 membranes. The outermost layer is called the dura mater. Dura mater that covers the brain has 2 layers, as opposed to the dura mater that covers the spinal cord. It's only 1 layer. Surrounding the brain, the dura mater has 2 layers. One that actually firmly adherent to the bone of the skull. It's called the periosteal layer. And we have an inner layer that is the meningeal layer. You cannot actually separate the two. They are as if they are 1 layer. They are strongly adherent to each other, and you cannot separate the two. Dura mater is a really, really tough membrane. As you're going to see in the lab, you need scissors to cut through it. So the inner periosteal layer attached, it's part of the bone, becomes part of the bone, and the inner meningeal layer firmly adherent to each other, but in certain areas they're going to separate, and they're going to be lined by endothelium, and they will be hosting what we know now as the venous sinuses of the brain. Okay, and we're going to talk about them in a little bit, on a little while. Okay, otherwise the 2 layers are firmly adherent to each other. Not only that, the inner layer or the meningeal layer of the dura mater is going to form certain folds that we're going to talk about them. First fold is actually this one here. Posteriorly, it is attached to the occipital bone, and this anterior limb is attached to the petrous part of the temporal bone, and anteriorly there's a free border, leaving a space for the brainstem to go through. As the name implies, tentorium, it comes from a tent. It's like a tent covering the cerebellum. Okay, so this is the first meningeal or dura mater fold. It's called the tentorium cerebelli, on top of the cerebellum, attached posteriorly to the occipital bone, anteriorly to the petrous part of the temporal bone, and it has a free margin, leaving a space for the brainstem to go through. That is the tentorium cerebelli or cerebelli. Now, hanging from the vault of the skull is the falx cerebri. Okay, falx cerebri. It's hanging from the vault of the skull, attached to crista galli. Remember the ethmoid bone here. In the middle, we have the crista galli. It is attached anterior to there. And below down here is a free border. Now, this falx cerebri goes into the longitudinal fissure between the 2 cerebral hemispheres. Okay, so this is the second fold, the falx cerebri, and as you can see here, The base is attached to the roof of the tentorium cerebelli. Anteriorly, it is attached to the crista galli of the ethmoid bone, and then we have the free margin down here. And as I mentioned, it is going to go into the longitudinal fissure between the two cerebral hemispheres. Now, again, this is falx cerebri. Do we have falx cerebelli? Yes, here between the two cerebellar hemispheres, attached to the base of the skull here, occipital bone, and it's going to go between to the right and left cerebellar hemispheres. It's a small, tiny little fold of that dura mater. So far we have three dural folds. The tentorium cerebelli covering, it's like a tent covering the cerebellum, okay, leaving a gap here for the passage of the brainstem. And then we have the falx cerebri hanging from the vault of the skull, running into the longitudinal fissure between the two cerebral hemispheres. And we have the falx cerebelli, double L, and it's going to go into between the right and left parts of the cerebellum. We have one more, actually, that is, see here the structure that is called the sella turcica, part of the sphenoid bone. Right, and in that you will have the pituitary gland. Pituitary gland is covered by another fold of the dura mater. It's called the diaphragma sella, and it's going to cover the pituitary gland completely, except a little hole that allow for the passage of the infundibulum that connects the pituitary gland with the hypothalamus. So this is the sella, diaphragma sella, that covers the sella turcica that hosts the pituitary gland. So we have four folds: tentorium cerebelli, falx cerebelli, and the diaphragma sella that covers the pituitary gland. Now, as I mentioned earlier, the dural layer of the dura mater is going to host, or the two layers actually of the dura mater, they're going to separate. Dura mater has two layers that covers the brain, has two layers, one periosteal attaches to the bone, and one the meningeal, the inner layer, and they are, as I mentioned, firmly adherent to each other. You cannot separate the two, except in certain areas where they separate and they become lined by endothelial cells so that they host the venous drainage of the whole brain. And we're going to call these areas where the dural layers separate and become lined by endothelium, and they receive the venous drainage of the brain as the dural venous sinuses. Now, at the base of the tentorium cerebelli here, we have the left transverse sinus, and we have the right transverse sinus. So two transverse sinuses, right and left. And at the base where the falx cerebri joins the tentorium cerebelli here, we have the straight sinus. Okay. Now, in the upper part of the falx cerebri, just below the vault of the skull, we have the superior sagittal sinus. In the free border of the falx cerebri, we have the inferior sagittal sinus. Now, all the superficial veins of the brain, they drain into the superior sagittal sinus. Inferior sagittal sinus, they also receive superficial vein and veins from the medial surface of the brain, because this falx cerebri goes into the longitudinal fissure between the two cerebral hemispheres. So the inferior sagittal sinus will receive the venous drainage from the medial side of the brain, and this straight sinus here will receive all the deep veins draining the brain. Deep veins, they drain into the straight sinus. We have bridging veins connecting the deep veins into the superficial veins, and those superficial veins will eventually drain into the superior sagittal sinus mostly, and the inferior sagittal sinus. So to recap what we have learned so far, at the base of the tentorium cerebelli, we have the right transverse sinus, we have the left transverse sinus, and here and at the upper border of the false cerebri, we have the superior sagittal sinus, S, and it's going to drain, it's going to go or continue into the right transverse sinus. Now, at the base where the false cerebri joins the tentorium cerebelli, we have the straight sinus, and it's going to continue into the left transverse sinus. So we have superior sagittal sinus goes to the right, straight sinus goes to the left, inferior sagittal sinus goes to the straight sinus. Are we done with the sinuses? No, not yet. I want to bring your attention to another important venous sinus, which is basically sitting on each side of the sella turcica that hosts the pituitary gland. And we have discussed that briefly when we discussed the blood supply to the brain. That is the cavernous sinus. So on each side of the brain, we have the cavernous sinus, of the sella turcica, I mean, we have the cavernous sinus. That is the location of the cavernous sinus. Now the cavernous sinus, that is the cavernous sinus here, right and left. The importance of the cavernous sinus is that it receives the superior ophthalmic vein, basically draining the eye, and that vein communicates with the facial vein draining the face. So any infection in the eye or the face can spread actually to the cavernous sinus. Okay, so it receives the superior ophthalmic vein, and it's received this vein here. It's called the sphenoparietal vein, just below the lesser wing of the sphenoid. These veins will drain into the cavernous sinus. Now, the cavernous sinus, because it receives the ophthalmic veins that communicates with the facial vein, is prone to infection and prone to thrombosis. Sometimes you have septic thrombosis of the cavernous sinus, and sometimes you have aseptic thrombosis. Septic thrombosis, as the name implies, is due to infection of the eye, infection of the nose, sinuses, teeth, can spread to the cavernous sinus, resulting sometimes to spread of the infection to the brain or in thrombosis. And sometimes you might have aseptic thrombosis in the cavernous sinus due to trauma, dehydration, and so on. Now, the risk with thrombosis or with the infection, you know what is located in the cavernous sinus. If you still remember, internal carotid artery goes through the cavernous sinus, and the cranial nerves 3, 4, and 6, responsible for eye movement. They also go through the cavernous sinus, where you have also the ophthalmic and maxillary divisions of the cranial nerve number 5. So whenever you have thrombosis or infection, there is a risk of paralysis of the eye movement, ophthalmoplegia, and loss of sensation of the face due to involvement of trigeminal nerve, maxillary, and the ophthalmic division. So this is the cavernous sinus. So as I said, receives the superior ophthalmic vein, receives the sphenoparietal vein. What happens to the cavernous sinus? It needs to drain its own the blood in it into the rest of the venous circulation. Actually, it's going to send us two veins. One, it's called the superior Petrosal sinus. That is the superior Petrosal sinus, again in the tentorium cerebelli, and as the name implies, in the petrous part. It lies over the petrous part of the temporal bone, and it's going to join the transverse sinus. And because we have superior Petrosal sinus, we have to have inferior Petrosal sinus. Inferior Petrosal sinus joins what we call the sigmoid sinus. So transverse sinus, after it is joined by the superior Petrosal sinus, will change its name. It becomes the sigmoid sinus. Sigmoid sinus runs on the base of the skull, and it's going to exit through the jugular foramen and becomes the jugular vein, internal jugular vein. Okay, so superior petrosal sinus coming from the cavernous sinus will go into the transverse sinus, and the inferior petrosal sinus will go into the sigmoid sinus. So basically, the transverse sinus, after it joins the superior petrosal sinus, becomes the sigmoid, and the sigmoid, after it joins the inferior petrosal sinus, it's going to continue into the jugular foramen and exit the base of the skull at the internal jugular vein. So to recap, remember, at the base of the tentorium cerebelli, we have the transverse sinus, right and left. Okay, and then we have the superior sagittal sinus in the false cerebri. It's going to go to the right. We have the inferior sagittal sinus. It's going to join the straight sinus, okay, at the base of the false cerebri, where it joins the tentorium cerebelli. Okay, and the straight sinus is going to go to the left transverse sinus. Now, from the cavernous sinus, we have the superior petrosal sinus joining the transverse sinus, okay, on both sides. And after that, the transverse sinus is going to change its name. It becomes the sigmoid sinus. Sigmoid sinus will receive the inferior petrosal sinus again from the cavernous sinus, and it's going to change its name again into the internal jugular vein. So the moment the sigmoid sinus exits the base of the skull through the jugular foramen, we're going to call it the internal jugular vein. So to summarize, all the venous sinuses of the brain eventually will lead to a single vein on each side, that is the internal jugular vein. Basically, all the venous drainage of the whole brain will go into the internal jugular vein. Here we have what we call the confluence of sinuses, where the superior sagittal meets the two transverse and the straight sinus. We have a tiny little sinus in the false cerebelli. It's called the occipital sinus as well. It joins the confluence of sinuses. Okay. Now, as I mentioned earlier, all sinuses eventually will lead to the sigmoid. Sigmoid will exit through the jugular foramen and becomes the internal jugular vein. Now, what do we have? The second membrane underneath the dura mater is the arachnoid. So on the outside here, this on the outside is the dura mater. On the inside is the arachnoid. Arachnoid basically lines the inner layer of the dura mater. You cannot separate the two. There is a potential space between the two, but actually you cannot see any space. There is a potential space between the dura and the arachnoid, but no actual space. Now then the arachnoid will be attached to the pia mater, which is the innermost layer. Pia mater actually is firmly adherent to the brain tissue, and it goes deep into the sulci. You cannot peel it off the brain tissue, okay? And there are fibers that connect the arachnoid with the pia mater, web-like structures, okay, or threads of connective tissue. And the importance of the space between the arachnoid and the pia mater, that is the subarachnoid space. This is the space that hosts the cerebrospinal fluid that nourishes the brain, and we're going to talk a little bit about it in a while. Okay, so this is the dura mater on the outside, arachnoid on the inside, no space in between. There is a potential space. The actual space is underneath the arachnoid, between the arachnoid and the pia mater, that is the subarachnoid space that hosts the cerebrospinal fluid. And as I mentioned, the pia mater is firmly adherent to the brain tissue. It's highly vascular, and also the cells of the pia mater in the area of the brain cavities, they contribute to the formation of the cerebrospinal fluid, plus the the choroidal plexus, which is the main source of the cerebrospinal fluid. So to recap, dura mater, 2 layers, periosteal, meningeal. We cannot separate the two except in the areas of venous sinuses. Otherwise, the 2 layers, they can consider it as a single layer. Underneath the dura mater, we have the arachnoid. There is a potential space between the dura and arachnoid, no actual space. And then arachnoid communicates with the pia mater in green through a web-like threads of connective tissue. And between the arachnoid and the pia mater, we have the subarachnoid space that contains the cerebrospinal fluid. And then we have the pia mater firmly adherent to the brain tissue and goes deep into the sulci of the brain. It is highly vascular and also in the area of the cavities of the brain contributes to the formation of cerebrospinal fluid together with the choroidal plexus. Now, what happens with these 3 layers or meninges after they exit the brain? They continue. They also cover the spinal cord. So the dura mater will continue to wrap the spinal cord, arachnoid as well, and the pia mater. And there are some differences that we're going to touch on them in a while. Now, let's start with the pia mater. Pia mater, similar to the pia mater of the brain, is firmly adherent to the tissue of the spinal cord. It goes in deep into the sulci. But, as you know by now, the spinal cord in adults ends at the level of L1, L2, between L1 and L2. What happens is that the pia mater, after it wraps the spinal cord, where the spinal cord ends at conus medullaris, is going to continue as a single cord that we're going to call filum terminale. This single cord will fix the spinal cord into the coccyx. So spinal cord is fixed into the coccyx by what we call the filum terminale, which is basically extension of the pia mater. What's going to happen to the dura mater and arachnoid? Dura mater is going to continue, and the only difference with the dura mater of the brain is that dura mater in this case surrounding the spinal cord is a single layer. We don't have a periosteal layer and a meningeal layer. It's a single layer, okay? And actually there is an actual space between the bone of the vertebra and the dura mater of the spinal cord, epidural space that is filled with fat and connective tissue, actually for added protection to the spinal cord. So it is a single layer, okay, and there is a epidural space between the bone and the dura mater filled with fat and connective tissue. Lining the dura mater is, as usual, the arachnoid, and arachnoid is connected to the pia mater by these coronal ligaments, denticulate ligaments here, okay, coronal ligaments attaching the arachnoid into the pia mater. The other thing you need to remember is that it is true that the spinal cord ends at L1, L2. Pia mater will continue as filum terminale to be attached to the coccyx. What happens to the dura mater and the arachnoid? Do they end at the level of L1 to L1 and L2, similar to the ending of the spinal cord? No. Actually, the dura mater and the arachnoid, they continue all the way down to S2, to the level of S2. So between L2 and S2, there is no spinal cord, but the meninges will continue. Why is that? Because of this. You remember this horse tail structure, coda equina? Let me, yes, remember this horse tail structure? This is called the coda equina. Now this is the filum terminale. This is the conus medullaris here, where the spinal cord ends at the level of L1, L2. And this is the extension of the pia mater. Filum terminale goes to the coccyx. And all these, like horse tail, are the spinal nerve roots before they exit into their or through their corresponding vertebra. You know, spinal nerves, they are very stubborn. They insist they exit below, through their corresponding vertebra. So if the spinal cord ends at the level of L2, what's going to happen to the rest of the lumbar and the sacral spinal nerves? They insist that they go down till they reach their corresponding vertebra, and then they will exit. So these descending spinal nerve roots below the end of the spinal cord at the level 2, which is basically all the spinal nerve roots forming spinal nerves between L2 and L5 and S1 and S5, they will form this structure, the horsetail-like structure. We call that the coda equina. Now, you cannot afford to leave this without nourishment. So you have to nourish it, and you have to protect it, and you have to surround it with cerebrospinal fluid. So that's why the dura mater and the arachnoid, they don't end here at the end of the spinal cord. They continue down to the level of S2. Okay? And the reason is that they want to contain the coda equina, these spinal nerve roots, and supply them with cerebrospinal fluid, and protect them with the cerebrospinal fluid. So the differences between the meninges of the brain and the spinal cord. Now remember, dura mater is only one layer, and there is an actual space between the bone and the dura mater, epidural space filled with fat and connective tissue. The other difference is that it's not an actual difference, but as a description, the dura mater and the arachnoid, they don't end where the spinal cord ends at the level of L1, L2. They actually continue down to the level of S2 so that they can contain the cerebrospinal fluid that will nourish and protect the coda equina, the descending spinal nerve rootlets from segments L2 to L5 and S1 to S5. Now, below the spinal, at the ending of the spinal cord, that is the safest area where you can take a sample of cerebrospinal fluid. This is called the lumbar system. Anywhere here below L2 is very safe to enter into the spinal, through the meninges with your needle. You go between usually they go between L3, L4, and they penetrate the dura mater, the arachnoid, and they will go into the subarachnoid space here, trying to withdraw the cerebrospinal fluid. You might ask, you know, طبعا the risk of damaging the spinal cord is zero, because we're doing it below the end of the spinal cord. What about damaging the spinal nerve roots? It's very minimal. It's negligible. It's actually zero, because, you know, imagine you put a number of threads, in a cup of water, okay, and then, you know, you bring a needle and you try to poke one of these threads. You cannot, simply because the moment you enter with your needle, the threads will swim away from your needle. So the area here just below the end of the spinal cord, it's called the lumbar system. Spinal cord ends here. You insert your needle here between L2, L3, L4, okay, and there is no risk of damage to the spinal cord, no risk of damage to the spinal nerve roots. Okay, so that's where you insert your needle at between L3, L4. It goes through the dura mater, arachnoid, subarachnoid, and then into subarachnoid space. That's where you can take a sample of the cerebrospinal fluid. It's called the spinal tap or the lumbar puncture. Now, last topic of this lecture is we're going to talk about ventricles of the brain. Now, the brain has 4 ventricles, and I usually ask, why do you need ventricles of the brain? The simple answer is that for 2 reasons. Number 1, so that the brain weighs less. Number 2, You fill these ventricles with cerebrospinal fluid that will nourish the brain with the needed nutrients and minerals. Okay, so how does it actually minimizes the weight of the brain? Now, I always refer to the whale story. You know, you have whales that weigh 5, 6, 10 tons, and as long as they are swimming in the ocean, they are fine. But the moment they go to the shore without the water, they will die simply because they will be crushed by their own weight. Now, the brain, as long as it is suspended in the cerebrospinal fluid, it's going to weigh about 25, 26 grams. But the moment you take it out and put it on a weighing scale without cerebrospinal fluid, it's going to weigh 1 kilo, 1.5 kilos, and even more. So if we leave the brain tissue that is very delicate without suspending it in cerebrospinal fluid, it's going to be very heavy and it's going to crush itself. So that's why we have ventricles. We have 4 ventricles. This C-shaped ventricle is called the 4th ventricle. We have 2 of them, one in each cerebral hemisphere. And then in between here, between the 2 thalami, we have the 3rd ventricle, and we have a duct. It's called the cerebral aqueduct that's going to connect the 3rd ventricle into the 4th ventricle. More details. Now, the lateral ventricles, we have 2 lateral ventricles. As I mentioned earlier, one in each cerebral hemisphere. It is C-shaped. Okay, it has an anterior horn that goes into the frontal lobe. It has an inferior horn that goes into the temporal lobe. It has a posterior horn that goes into the occipital lobe. And here we have the body, and the body leads to the antrum. Okay, the body is in the parietal lobe. So frontal lobe, occipital lobe, temporal lobe, and the body. This is the frontal horn. This is the inferior horn. That is the posterior horn that goes to the occipital lobe, and the body is in the parietal lobe. Now, how do they communicate with the 3rd ventricle here? They have what we call the foramen of Monroe. Each will have a foramen of Monroe that will communicate with the 3rd ventricle. This is the lateral ventricle here. That is the 3rd ventricle between the 2 thalami, and this is the 4th ventricle here. Now, between the lateral ventricle and the 3rd ventricle on each side, there is a foramen of Monroe. Okay, so we have 2 foramen of Monroe between the lateral ventricle, the lateral ventricles, and the 3rd ventricle. Okay, again, this is another image of the lateral ventricle, that the posterior horn goes to the occipital lobe here. That is the inferior horn, that is the body, and so on. Okay, and they will, this is the lateral ventricle. Separating the 2, if you do a sagittal section of the brain, between the 2 lateral ventricles, there is a septum here. When we were students, we used to enjoy piercing this septum so that your fingers goes deep into the lateral ventricle. It's called the septum pillucidum. So there is a lateral ventricle on this side, and another lateral ventricle on the other side that has been removed. Okay, now each lateral ventricle will communicate with this. This is a space that is located between the 2 thalami. It is called the 3rd ventricle. Okay, we have a foramen of Monroe communicating the lateral ventricle with the 3rd ventricle. Okay, and then from the 3rd ventricle through the cerebral aqueduct into the 4th ventricle that we're going to see later on. Okay, now this is a sagittal section. This is the septum pillucidum. If I pierce that, it will lead me to the lateral ventricle. This is the area of the 3rd ventricle. This is the thalamus. The other thalamus has been removed. So the space between the 2 thalami is the 3rd ventricle communicating, or from the lateral ventricle, we have foramen of Monroe that will lead to the 3rd ventricle, and then we have the cerebral aqueduct running through the midbrain for 1.5 to 2 centimeters, leading to the 4th ventricle. Now this is, again, this is the thalamus, that is the other thalamus, and this is the 3rd ventricle, and this is the lateral ventricle. Okay, and the two communicate through the foramina of Monroe. Okay, now the fourth ventricle is a diamond shaped, okay, located between the cerebellum and the bones. Okay, as you can see, it is diamond in shape. Okay, and it leads directly to the central canal of the spinal cord. Okay, but which is a dead end. It's not going to lead us anywhere. So what's going to happen to the cerebrospinal fluid that is eventually going to reach the fourth ventricle? It's going to exit through three foramina. One is called the foramen of Monroe here. So it's going to leak the cerebrospinal fluid to the subarachnoid space surrounding the spinal cord. And here we have two foramina. We call them foramina of Luschka. That's going to leak the cerebrospinal fluid into the subarachnoid space surrounding the brain. So to summarize, actually, cerebrospinal fluid that is formed by choroid plexus in the ventricles, it's going to go from the lateral ventricle through the foramen of Monroe to the third ventricle, and from there through cerebral aqueduct to the fourth ventricle. Now from the fourth ventricle is going to lead to the central canal of the spinal cord, which is a dead end, but also is going to come out through three foramina. Foramina of Monroe that leads to subarachnoid space surrounding the spinal cord, and foramina of Luschka, we have two of them that will lead to subarachnoid space surrounding the brain. So Monroe is here, so CSF is going to go out into subarachnoid space surrounding the spinal cord, and from Luschka, it's going to go into subarachnoid space surrounding the brain. Now CSF, there's a continuous production of CSF. You produce about 500 mils of CSF every day. But at each given time, there is only 50 to 150 mils of CSF in the ventricular system. So which means that, you know, there is production and there is also absorption of the cerebrospinal fluid. As you know, cerebrospinal fluid is produced in the choroid plexus and the ventricles with the help of the pia mater and whatever plasma fluid that is lost at the level of the capillaries. From the lateral ventricle, third ventricle, cerebral aqueduct, and fourth ventricle to subarachnoid space. Okay, subarachnoid space, and from there it needs to be absorbed. So it reaches this area just inferior to the superior sagittal sinus. From there, there is a structure that we call the arachnoid granulation that will actually take this cerebrospinal fluid, and due to you know, a pressure gradient or differences, it's going to go into the superior sagittal sinus. From there to the venous drainage of the brain, to the internal jugular vein, back to the circulation. Okay, so from the arachnoid, subarachnoid space, arachnoid granulation, superior sagittal sinus, to the rest of the venous drainage of the brain. Now, what happens if there is an imbalance between production and absorption? You will have accumulation of the cerebrospinal fluid that is called the hydrocephalus or hydrocephalus. You can say it both ways. Now, we have three types of hydrocephalus. Either there is excessive production of CSF in case of, for example, tumor of the choroid plexus papilloma, or you have less absorption by the subarachnoid granulation in case of infection, subarachnoid hemorrhage, that is called the communicating hydrocephalus. So either excessive production, tumor, less absorption, communicating hydrocephalus, for example, infection, or we have a third type that is called non-communicating hydrocephalus. As the name implies, CSF is not communicating, is not going through the cycle. Tumor or something is blocking the pathway of CSF. And this is the third type of hydrocephalus. Thank you, and we're done.